Okay, now let us start with chapter 55th of your Apurva Sastry Essentials of Microbiology, which is about miscellaneous bacterial infections of skin and soft tissues. In this chapter, we will be previewing anthrax, actinomycetes infection, non-venereal treponematosis, and other bacterial SSTIs. So, in this video, we will be covering anthrax and actinomycetes infection, while the non-venereal treponematosis and the other bacterial SSTIs will be covered in the subsequent videos. This chapter covers various bacterial skin and soft tissue infections such as anthrax, actinomycosis, nocardiosis, non-venereal treponematosis, and others. Anthrax. Anthrax is a zoonotic disease caused by a spore-forming obligate aerobe Bacillus anthracis. It mainly affects in animals. Humans acquire the infection through contact with an infected animal or by inhaling spores. It has also gained importance recently because of its ability to be used as a biological weapon. Historical importance. Considerable historical interest is attached to anthrax bacillus due to the following reasons. It was the first pathogenic bacterium seen under microscope by Paulander in 1849. It was the first bacterium to be isolated in pure culture by Robert Koch 1876, and the Koch postulates were made based on Bacillus anthracis. Anthrax vaccine was the first live attenuated bacterial vaccine prepared by Louis Pasteur in 1881. Virulence factors and pathogenesis. Pathogenesis of anthrax is due to two important virulence factors, anthrax toxin and capsule. Anthrax toxin. It is a tripartite toxin consisting of three fragments: edema factor, protective factor, and lethal factor. The edema factor is the active fragment. It acts as a adenylyl cyclase and increases host cell cyclic AMP, cyclic adenosine monophosphatase. It is responsible for edema and other manifestations seen in the anthrax. Protective factor, it is the binding fragment that binds to the host cell receptors and facilitates the entry of other fragments into the host cells. Lethal factor causes cell death, acts by cleaving host cell MAPK, mitogen activated protein kinases. These fragments are not toxic individually, but in combination they produce local edema and generalized shock. Toxin synthesis is controlled by plasmid PXO1. Loss of plasmid makes the strain avirulent. This was probably the basis of original anthrax vaccine prepared by Pasteur. Anthrax capsule. Bacillus anthracis has a polypeptide capsule made up of polyglutamate in contrast to polysaccharide capsule present in most of the other capsulated bacteria. Capsule is plasmid PX02 coded. It inhibits complement mediated phagocytosis. Clinical manifestation: animal anthrax. Anthrax is primarily a zoonotic disease. Herbivorous animals such as cattle, sheep, and less often horses and pigs are affected more commonly than the carnivorous animals. Infection occurs in susceptible animals by ingestion of the spores present in the soil. Direct spread from animal to animal is rare. Anthrax in animals presents as a fatal septicemia. However, localized cutaneous lesions may be produced rarely. Infected animals discharge large number of bacilli from the mouth, nose, and rectum. These bacilli sporulate in the soil and remain as the source of infection for man. Human anthrax. Transmission: human beings acquire infection by cutaneous mode by spores entering through the abraded skin, seen in people with occupational exposure to animals, most common mode. Inhalation of spores. Ingestion of carcasses of animals dying of anthrax containing spores manifested as bloody diarrhea. Now in this table we can see a difference between cutaneous anthrax and pulmonary anthrax. We'll review it in some time. Now in this image, we can see a malignant pustule of anthrax. Clinical types: there are mainly three types of human anthrax: cutaneous anthrax, pulmonary anthrax, and intestinal anthrax. It is rare. The intestinal anthrax is rare, occurs due to ingestion of spores contaminated with meat of animals dying of anthrax. It is highly fatal and manifests as bloody diarrhea. Now, coming back to the table, feature of cutaneous anthrax is hide porter disease. It commonly occurs in dock workers carrying loads of hides and skins on their bare backs. Transmission is by cutaneous exposure to spores which enter through abraded skin. Characterized by malignant pustule, as we have seen in the image, the lesion begins as papule that evolves into a painless vesicle followed by the development of a coal black necrotic eschar surrounding non-pitting edema, indurated edema. The name anthrax, which means coal, comes from the black color of the eschar. However, it is non-malignant condition. Occupational exposure, dock worker, butcher, abattoir, and farmer. Occurrence most common 95% prognosis self-limiting rarely becomes fatal if untreated, rarely associated with bioterrorism. Now coming on to pulmonary anthrax, it's called wool sorter's disease as it is seen in workers of wool factory who acquire infection by inhalation of dust from infected wool. Transmission is by inhalation of spores. Characteristics are hemorrhagic pneumonia, bacilli spread by lymphatics or blood, leading to bacteremia, hemorrhagic mediastinitis, hemorrhagic meningitis. Occupational exposure, workers of wool factory. Occurrence rare, prognosis is fatal, and bioterrorism. Most common form of anthrax to be associated with bioterrorism is this. Now comes an important topic, agents of bioterrorism. Bacillus anthracis, one of the most common agent of bioterrorism, has been widely used in various biological warfare such as outbreaks in Sverdlovsk in 1979 and in United States in 2001. Pulmonary anthrax is the most common form to cause bioterrorism outbreaks. Transmission occurs by inhalation of anthrax spores from contaminated animal products. Though it has a high fertility with prompt initiation of antibiotic therapy, survival is possible. Epidemiology. Incidence of human anthrax is highest in Africa and Central and Southern Asia. Human anthrax may be of two types: non-industrial cases. These result from agricultural exposure to animals. Industrial cases. These result from infected animal products such as hides, hair, bristles, and wools. Now coming on to lab diagnosis, specimen are pus, sputum, blood, CSF, direct demonstration, gram staining, gram positive, large rectangular bacilli. McFadden's reaction shows amorphous purple capsule surrounding blue bacilli, polychrome methylene blue stain. Direct immunofluorescence detects capsular antigen, and Ascoli's thermoprecipitation test, it is also positive for Bacillus anthracis. Culture, nutrient agar, medusa head appearance in colonies. Blood agar, dry wrinkled non-hemolytic colonies. Gelatin stab agar, inverted fir tree appearance growth. Selective media is solid medium with penicillin, string of pearl appearance, and PLET medium. Culture smear gram positive rods with bamboo stick appearance. Antibody detection by ELISA and molecular diagnosis by PCR using BAPX01 or 02 primers. Lab diagnosis, there is a high risk of laboratory acquired infection of anthrax, hence utmost precaution should be taken and specimen should be processed and in appropriate biological safety cabinets. Specimen collection, specimen should be collected before starting antibiotic treatment. The useful specimens are pus, swab or tissue from the malignant pustule, sputum in pulmonary anthrax, blood in septicemia, CSF in hemorrhagic meningitis, gastric aspirate feces or food in intestinal anthrax, earlobes from dead animals. Direct demonstration, gram staining reveals gram positive large rectangular rods 3 to 10 micrometer to 1 to 1.6 micrometer. Spores are usually not seen in clinical samples. McFadden's reaction, polypeptide capsule can be demonstrated by staining with Gers polychrome methylene blue stain for 30 seconds. Capsule appears as amorphous purple material surrounding the blue bacilli. This is used for presumptive diagnosis of anthrax in animal. Direct immunofluorescence test, direct IF. It detects capsular and cell wall polypeptide antigens by using fluorescent tagged monoclonal antibodies. It is used for confirmation of diagnosis during bioterrorism outbreaks. Ascoli's thermoprecipitation test is a ring precipitation test performed when specimens are received in the putrid form. Culture. Bacillus anthracis is aerobic, non-fastidious, growing in ordinary media and has a wide temperature range, 12 to 45 degrees Celsius of growth. Colony morphology of Bacillus anthracis after 24 hours incubation of plates is as follows. Nutrient agar colonies are 2 to 3 mm in size, irregular, round, opaque, grayish white and with a frosted glass appearance. Medusa head appearance, when colonies are viewed under a low power microscope, the edge of the colony, which is composed of long interlacing chains of bacilli, appear as locks of matted hair. Blood agar, it produces dry, wrinkled, non-hemolytic colonies. Gelatin stab agar growth occurs as inverted fir tree appearance due to liquefaction of gelatin, which occurs maximum at the surface and then slows down towards the bottom. Selective media, solid medium with penicillin colony smear shows bacilli arranged in string of pearl appearance. PLET medium consists of polymyxine, lysozyme, EDTA, and thallus acetate added in the heart infusion agar. Now, in the images, we see uh, in the figure A, we see gram stain of Bacillus anthracis, and the direct smear shows gram positive large rectangular bacilli with pus cells, while figure B shows gram positive bacilli with non-bulging spores, bamboo stick appearance. Okay, now in these images, figure A shows McFadden's reaction, amorphous purple capsule surrounding the blue bacilli, polychrome methylene blue stain. Figure B shows medusa head colonies of Bacillus anthracis on nutrient agar on 10x magnification. Figure C shows non-hemolytic dry wrinkled colonies of Bacillus anthracis on blood agar. Now, coming on to culture smear. Gram staining reveals bamboo stick appearance, that is, long chain of gram-positive bacilli within non-bulging spores appear as empty spaces. Spores of bacillus should be differentiated from that of bulging spores of other gram-positive bacillus clostridium spores. They can be demonstrated by using special stains such as hot malachite green, Ashby's method, or modified acid-fast staining using 0.25% sulfuric acid spores or acid-fast. Molecular diagnosis. PCR with specific primers can be used for further confirmation. PCR using BAPX01 primer targeting gene coding for protective antigen. PCR BAPX02 primer targeting capsular gene. Anthrax treatment. Anthrax can be successfully treated if the disease is promptly recognized and appropriate therapy is initiated early. Cutaneous anthrax, amoxicillin, ciprofloxacin, or doxycycline for 7 to 10 days. Pulmonary or intestinal anthrax treatment comprises of antibiotic regime along with anthrax immunoglobulin. Post-exposure prophylaxis following exposure, ciprofloxacin or doxycycline is given for 60 days along with anthrax vaccine Biothrax 3 doses. Prevention. The general control measures include disposal of animal carcasses by burning or by deep burial in lime pits. Decontamination usually by autoclaving of the animal products. Protective clothing and gloves for handling potentially infectious material. Live attenuated non-capsulated spore vaccine. It is commercially available as Stern vaccine, which is extensively used in animals, remains protective for 1 year following single injection. However, it is not safe for human use. Adsorbed alum precipitated toxoid vaccine. It is prepared from the protective antigen. Antibodies formed against protective antigen neutralize it and thus prevent attachment of toxin to the host cell. It is safe and effective for human use. Example, Biothrax. It is indicated for pre-exposure and post-exposure prophylaxis. Other bacillus species of human importance, anthracoid bacilli. Bacillus species other than the anthrax bacillus are collectively called as anthracoid bacilli. Now, in this figure, in this table, we can see the adsorbed anthrax vaccine, Biothrax. Indication: pre-exposure prophylaxis for person at high risk of exposure. Route is intramuscular, 0.5 ml per dose. Dosing schedule is primarily series 0, 1 and 6 months. Boosters at 6 and 12 months after primary series and then yearly. Post-exposure prophylaxis following exposure to suspected or confirmed case. Route is subcutaneous, 0.5 ml per dose. Dosing schedule is 0, 2 and 4 weeks post-exposure combined with antimicrobial therapy. Now about the anthracoid series, except Bacillus cereus, most of them are non-pathogenic and are common contaminants in the laboratory cultures. They have a general resemblance to anthrax bacilli, such as producing dry wrinkled colonies. In smear, they appear as chains of spore-bearing gram-positive bacilli. However, they differ from anthrax bacilli in many ways, such as they are motile and produce hemolytic colonies on blood agar, etc. Bacillus cereus, the normal inhabitant of soil, also widely isolated from food items such as vegetables, milk, cereal, spices, meat, and poultry. It mainly causes food poisoning, can also cause ocular and various other systemic infections. Bacillus thuringiens, it's closely related to Bacillus cereus and may occasionally produce food poisoning. It is also used as larvicidal agent for mosquito control. Bacillus spore used as sterilization control. Bacillus species are used as biological indicators to check the efficacy of sterilization processes. For example, Geobacillus stereothermophilus, formerly Bacillus stereothermophilus, is used for autoclave, hydrogen peroxide gas plasma sterilizer, and liquid acetic acid sterilizer. Bacillus atrophius is used for ethylene oxide sterilizer and dry heat sterilizer. Now, coming on to actinomycetes infection. Actinomycetes are a diverse group of gram-positive bacilli arranged in chains or branching filaments. Though they are true bacteria but similar to fungi, they form a mycelial network of branching filaments. Most of them are soil saprophytes or normal human commensals. Important genera include actinomyces. They are anaerobe and non-acid fast, produce a clinical condition called actinomycosis. Nocardia, they are aerobe and acid fast, cause actinomycetoma and pulmonary infection. Actinomedura, they are aerobe and non-acid fast, cause actinomycetoma. Streptomyces, they are aerobe and non-acid fast, rarely cause actinomycetoma in man. They also remain as an important source of antibiotics such as streptomycin. Thermophilic actinomycetes such as micropolyspora and thermoactinomyces can cause hypersensitivity, pneumonitis, farmer's lung, and bag- bagasosis. Actinomycosis. Actinomyces are soil saprophytes and commensals of oral cavity. In humans, they cause actinomycosis. Actinomycosis israeli is the most common species infecting man. Pathogenesis. Actinomycosis is a chronic suppurative and granulomatous infection characterized by multiple abscesses with formation of sinuses, discharge containing granules, and on later stage fibrosis and tissue destruction. The name refers to ray-like appearance of the organism in the granules actinomyces, meaning ray fungus. Mode of infection. As actinomyces are commensals of oral cavity, the infection is mostly endogenous and may result from trauma, example dental extraction. The bacteria bridge the mucosal or epithelial surface of the mouth, grow in an anaerobic niche, induce a mixed inflammatory response, and form a painless indurated swelling with a sinus which may drain pus containing granules to the skin surface. The infection may spread to the neighboring organs, including the bones, which induce tissue destruction. Often, the hard indurated swelling described as wooden are mistaken as malignant tumors. Clinical manifestation of actinomycosis. Oral cervicofacial actinomycosis is the most common form, usually presents as painless, slow growing hard mass with cutaneous fistulas, a condition commonly known as lumpy jaw. The other forms are rare, such as thoracic actinomycosis may present as cavitary lesions and pleural effusion. Abdominal form, it occurs due to the spillage of intestinal flora secondary to bowel surgery or other conditions of bowel such as appendicitis. Pelvic form occurs following intrauterine contraceptive devices IUCDs insertion. Brain abscesses, bone destruction and soft tissue infection. Disseminated form may occur due to hematogenous spread. Lungs and liver are the common sites where the multiple nodules are formed. Dental caries and periodontal diseases mainly caused by actinomyces neslandii and actinomyces odontolyticus. Now, laboratory diagnosis specimen. Based on the affected site, the specimen collected include discharge from the sinus or fistula, release sputum, bronchial washings, and cervicovaginal secretions. Direct microscopy. Pus discharge is thoroughly washed in saline in a test tube, and the sediment is collected that contains gritty white or yellowish sulfur granules of less than 5 mm in size. Granules are crushed between the two slides and smears are made. Because actinomycetes are part of normal oral and genital tract flora, their isolation in the absence of sulfur granule specimen is of less significance. Gram staining down Bren modification, it shows a central mass of gram positive branching, filamentous bacilli radiating peripherally with hyaline club shaped ends. Now let us see the figures. In figure A, we see the actinomycosis, a painless, slow-growing hard mass with cutaneous fistula. In figure B, we see gram-positive filamentous bacilli, and in C, we see Komori stained smear showing sun ray appearance. Okay, now granules of actinomycosis are hard and non-emulsifiable, which differentiates them from granules produced in the other conditions. Histopathological staging such as hematoxylin, eosin, and Gomori stained tissue secretions may reveal granules composed of eosinophilic clumps surrounding basophilic filaments and inflammatory cells such as neutrophils and foamy macrophages. Sun ray appearance. Culture. Pus containing sulfur granules are washed and cultured anaerobically at 37 degrees Celsius on media such as thioglycolate broth. Growth of actinomyces israeli resembles fluffy balls at the bottom of the tube. This can be differentiated from other species. Actinomyces bovis produce uniform turbidity. Brain heart infusion agar. It forms small spidery colonies at 48 hours which become enlarged and heaped up in 10 days. Species identification. It is done when the culture isolate is subjected to biochemical reactions. Automated methods such as MALDI-TOF, molecular methods such as PCR detecting 16S rRNA gene are also available for the speciation. Treatment of actinomycosis. A recommended regime includes IV ampicillin or IV penicillin G for 4 to 6 weeks, followed by oral penicillin V or amoxicillin for 6 to 12 months. Lesser duration may cause relapse. Doxycycline, ceftriaxone, or clindamycin can be given to people with penicillin allergy. Surgical removal of affected tissues may be required for extensive lesions. Now coming to nocardiosis. Nocardia species named after Edmund Nocard 1898 are gram-positive branching filamentous bacilli similar to actinomyces. However, they differ from the latter by being aerobic and acid-fast. They are environmental saprophytes and found in soil and vegetation. Though more than 100 species have been identified, only few 9 species are associated with human disease. Nocardia asteroides, so named due to its star-shaped colonies, and Nocardia brasiliensis are the most common pathogens. Pathology and pathogenesis. Nocardiosis occurs worldwide, more common among adult males. Soil is the natural habitat of Nocardia. Infection is acquired from soil either by inhalation of fragmented bacterial filaments, leads to development of pulmonary nocardiosis that may disseminate later, or transcutaneous inoculation of bacteria leads to various cutaneous and subcutaneous manifestation. Example, mycetoma. Person to person spread is not known. Now, in this table, we can see the differences between actinomycosis and actinomyces and nocardia. Acid fastness, non-acid fast are actinomyces and partially acid fast are nocardia. Oxygen requirement, actinomyces are anaerobes while nocardia are obligate aerobes. Habitat of actinomyces found as oral flora infections occur endogenously, while of nocardia usually habitat is soil and infections occur exogenously. Risk factors of actinomyces disease occurs in immunocompetent host also, while nocardia usually affects people with low immunity. About actinomyces clinical forms, cervicofacial, abdominal and other forms are seen, while in nocardia pulmonary, CNS form and actinomycetoma are seen. About granules of actinomyces, sulfur granules are hard and non-emulsifiable, consist of branching filamentous bacilli and surrounded by clubs sun ray appearance. While for nocardia, granules are soft and lobulated and also show sun ray appearance, commonly found in mycetoma, rare in other conditions. Culturing of actinomyces is by spidery molar teeth colony in solid media, and appearance is like fluffy ball at the bottom of liquid medium. About nocardia, the colonies are creamy, wrinkled, and pink. Isolation is done in selective media, paraffin bait technique, and LG media. Treatment of actinomyces by penicillin, while of nocardia is by cotrimoxazole. Now, the risk factor cell mediated immunity plays an important role in controlling the disease. Hence, nocardia act as opportunistic pathogen, tend to occur frequently in immunocompromised conditions, including AIDS, corticosteroid treatment, organ transplantation, and tuberculosis. Clinical manifestations, pulmonary nocardiosis. Lower pneumonia is the most common form of pulmonary nocardiosis, characterized by subacute onset of cough with thick purulent sputum. It may rarely spread directly to adjacent tissues, leading to pericarditis, mediastinitis, laryngitis, tracheitis, and bronchitis. Extrapulmonary disseminated nocardiosis. In half of the pulmonary nocardiosis cases, dissemination occurs via blood and typically presents as subacute abscess. Brain abscess is the most common form, followed by the abscess of skin, kidney, bone, and muscle. Actinomycetoma. Actinomycetoma is the chronic granulomatous condition of bacterial etiology characterized by subcutaneous nodular swelling, multiple sinuses, and discharge containing granules. This condition can also be caused by fungi known as eumycetoma. Lab diagnosis. Specimen, depending on the site affected, various specimens collected such as sputum, pus from abscess and granules. Granules are present in discharge and collected in sterile gauze or loop by pressing the sinuses from the periphery to express them out, as in case of actinomycetoma. Direct microscopy, gram staining brown Brent modification reveals gram positive branching and filamentous bacilli of width 0.5 to 1 micrometer. Modified acid fast staining using 1% sulfuric acid as decolorizer, Kin-Young method. Nocardia are partially acid fast and appear as branching and filamentous red colored acid fast bacilli. Granules are washed several times in saline, crushed between two slides and observed under microscope. Granules are 0.5 to 2 mm sized microcolonies composed of branching filamentous bacilli. Histopathology H&E stain of the granule shows multilobulated with sun ray appearance. Culture. Nocardia are obligate and aerobes that grow on various media such as brain, heart infusion agar, saburod dextrose agar SDA when incubated at 37 degrees Celsius for 2 days to 2 weeks. Colonies are creamy, wrinkled, pigmented, orange or pink color and adhere firmly to the medium. Some colonies possess abundant aerial growth and have a cotton wool ball appearance. In this figure, we can see the acid-fast filamentous branching bacilli of nocardia in the modified acid-fast strain. Now, the recovery of nocardia from the samples containing actinomedulla and streptomyces can be done by using selective media buffered yeast extract containing polymyxine and vancomycin, saboraud dextrose agar with chloramphenicol. Paraffin bed technique media using paraffin as a sole carbon source have been shown to be effective for isolation of nocardia from soil and clinical samples. Loestrine Jensen medium produces moist glabrous colonies differentiate from microbacteria. Identification species identification is made by appropriate biochemical tests or automated methods such as Malritov. Treatment. Cotrimoxazole are the drug of choice for all forms of nocardiosis. For severe disease such as brain abscess or pneumonia, cotrimoxazole plus imipenem is recommended. Duration of treatment for severe diseases 6 to 12 months for intact host defense or 1 year for deficient host defense. For lymphadenitis, skin abscess 2 months. For actinomycetoma until 6 to 12 months after cure. For keratitis until 2 months after cure. Aspiration or drainage of the abscesses should be carried out to limit the spread of infection. Now, actinomedulla infections. Actinomedulla is the most frequent cause of actinomycetoma, significantly outnumbering the cases caused by nocardia. Actinomedulla medullae and actinomedulla pelletieri are important species. Granules are usually white to yellow except in case of Actinomedulla pelletieri that produce red colored granules. Microscopy of the specimen containing granules reveals branching filamentous bacilli. Colonies have a molar tooth appearance after 48 hours in culture with sparse aerial growth. Most isolate are susceptible to amikacin and imipenem. Okay, so this completes our part 1 of the chapter. Now the non-venereal typonematosis and other bacterial SSTIs will be covering in the next video. Okay, so like, share, subscribe. Thanks for watching.